This recording will go over gastric cancer. Most cancers of the stomach are adenocarcinomas. Often there are no symptoms in the early stages, and the disease is advanced when detected. Gastric cancer usually begins in the glands of the stomach mucosa. Atrophic gastritis and intestinal metaplasia or abnormal tissue development are precancerous conditions. Inadequate acid secretion in patients with atrophic gastritis creates an alkaline environment that allows bacteria, especially H. pylori, to multiply. Gastric cancer spread by direct extension through the gastric wall and into regional lymphatics, which carry tumor deposits to lymph nodes. Direct invasion of and adherence to adjacent organs, such as the liver, pancreas, or transverse colon, may also result. Hematogenous spread via the portal vein to the liver and via the systemic circulation to the lungs and bones is the most common mode of metastasis. Infection with H. pylori is the largest risk factor for gastric cancer because it carries the cytokine-associated gene A gene. Patients with pernicious anemia, gastric polyps, chronic atrophic gastritis, or achlorhydria, which is absence of secretion of hydrochloric acid, are 2 to 3 times more likely to develop gastric cancer. The disease also seems to be positively correlated with eating pickled food, nitrates from processed foods, and salt added to food. A low intake of fruits and vegetables is also a risk factor for cancer. Gastric surgery seems to increase the risk for gastric cancer because of the eventual development of atrophic gastritis, which results in changes to the mucosa. Patients with Barrett's esophagus from prolonged or severe GERD have an increased risk for cancer in the cardia at the point where the stomach connects to the esophagus. Teach patients with gastritis and/or H. pylori infection to follow the treatment regimen to ensure that gastritis heals and H. pylori infection is eliminated. Stress the need for eating a well-balanced diet and limiting pickled, salted, or processed foods to help prevent gastric cancer. Please review the chart in your book that goes over key features of early versus advanced gastric cancer. The healthcare provider uses an EGD with biopsy for definitive diagnosis of gastric cancer. Endoscopic ultrasound or EUS, CTs, PET scans, and MRI can also be used to determine the extent of the disease and be used for planning therapy. Management of gastric cancer includes drug therapy, radiation, and/or surgery. The treatment of gastric cancer depends highly on the stage of the disease. Combination chemotherapy with multiple cycles of drugs before and after surgery may be given. Although gastric cancers are somewhat sensitive to the effects of radiation, the use of this treatment is limited because the disease is often widely spread to other abdominal organs on diagnosis. Surgical resection by removing the tumor is the preferred method for treating gastric cancer. In regards to pre-op care, before conventional open approach surgery, a NG tube is often inserted and connected to suction to remove secretions and empty the stomach. The NG tube remains in place for a few days after surgery to prevent the accumulation of secretions, which may lead to vomiting or GI distension and pressure on the incision. Patients having laparoscopic surgery or minimally invasive surgery do not require an NG tube. Because weight loss is problematic for patients with gastric cancer, nutrition therapy is a vital aspect of pre-op and post-op management. To correct malnutrition before surgery, the healthcare provider may prescribe enteral supplements to the diet and/or total parenteral nutrition or TPN. Vitamin, mineral, iron, and protein supplements are essential to correct nutritional deficits. In regards to the operative procedure, the surgeon usually removes part of or all of the stomach to take out the tumor. Total gastrectomy with anastomosis of the esophagus to the jejunum is the principal surgical intervention for extensive gastric cancer. In regards to post-op care, provide the usual post-op care for patients who have had general anesthesia to prevent atelectasis, paralytic ileus, wound infection, and peritonitis. Auscultate the lungs for adventitious sounds and monitor for the return of bowel sounds. Take vital signs as appropriate to detect signs of infection or bleeding. Aggressive pulmonary exercises and early ambulation can help prevent respiratory complications and deep vein thrombosis. Also, inspect the operative site every 8 to 12 hours for the presence of redness, swelling, or drainage, which indicate wound infection. Keep the head of the bed elevated to prevent aspiration from reflux. Decreased patency caused by a clogged NG tube can result in acute gastric dilation after surgery. The problem is characterized by epigastric pain and a feeling of fullness, hiccups, tachycardia, and hypotension. Notify the surgeon to obtain an order for irrigation or replacement of NG tube to relieve these symptoms. Dumping syndrome is a term that refers to a group of vasomotor symptoms that occur after eating. This syndrome is believed to occur as a result of rapid emptying of the food contents into the small intestine, which shifts fluid into the gut, causing abdominal distension. Observe for early manifestations of this symptom, which typically occur within 30 minutes of eating. Symptoms include vertigo, tachycardia, syncope, sweating, pallor, palpitations, and the desire to lie down. Report these manifestations to the surgeon and encourage the patient to lie down. Monitor the patient for late symptoms. Late dumping symptoms, which occur 90 minutes to 3 hours after eating, is caused by a release of an excessive amount of insulin. The insulin release follows a rapid rise in the blood glucose level that results from the rapid entry of high-carb food into the jejunum. Observe for manifestations including dizziness, lightheadedness, palpitations, diaphoresis, and confusion. Dumping syndrome is managed by nutrition changes that include decreasing the amount of food taken at one time and eliminating liquids ingested with meals. In collaboration with the dietitian, teach the patient to eat a high-protein, high-fat, low to moderate carb diet. Medications may also be given to decrease carb absorption and decrease gastric and intestinal hormone secretion, which slows stomach and intestinal transit time. Please review the table that goes over a diet for dumping syndrome on your own. Alkaline reflux gastropathy, also known as bioreflux gastropathy, is a complication of gastric surgery in which the pylorus is bypassed or removed. Endoscopic examination reveals regurgitated bile in the stomach and mucosal hyperemia. Symptoms include early satiety, satisfied quickly with little food, abdominal discomfort, and vomiting. Delayed gastric emptying is often present after gastric surgery and usually resolves within 1 week. Edema at the anastomosis or surgical connection areas or adhesions such as scar tissue obstruct the distal loop and may cause mechanical blockage. Several problems related to nutrition develop as a result of partial removal of the stomach, including deficiencies of vitamin B12, folic acid, and iron, impaired calcium metabolism, and reduced absorption of calcium and vitamin D. These problems are caused by a reduction of intrinsic factor. In the absence of intrinsic factor, signs and symptoms of pernicious anemia may occur. Assess for the development of atrophic glossitis secondary to vitamin B12 deficiency. In atrophic glossitis, the tongue takes on a shiny, smooth, and beefy appearance. Monitor the CBC for signs of megaloblastic anemia, or low red blood cell count level, and leukopenia, low white blood cell count level. These manifestations are corrected by the administration of vitamin B12. The healthcare provider may also prescribe folic acid or iron preparations. Please review care coordination and transition management on your own, paying special attention to the interventions to minimize dumping syndrome and decrease gastric stimulants. Go ahead and pause the video so that you can read the questions and pick out your answer. For case study question number 1, if you chose the answer C, you are correct. For case study question number 2, if you chose the answers A, C, and D as in dog, you are correct. For case study number 3, if you chose the answer A, you are correct. For case study number 4 question, if you chose answer D, you are correct. And the final case study question, the correct answers are A, C, D, and E. For question 1, the correct answer is C. For question 2, the correct answer is D as in dog. And for question 3, the correct answer is C.